Hello, this is Michael Romanins from the Vascular Risk Foundation. We propose a risk calculator which also gives you some information about therapeutic options in your patient, whether you should increase a statin dose, if you should give aspirin, and if you should use Xarelto Vascular. The calculator is purely numeric and adds you as a tool of artificial intelligence in your daily busy practice. So let us have a look at this calculator, which is freely available in the internet and which we try to improve constantly. And so what information do we need about the patient? Well, we have to see if he has indication for intensive risk-lowering therapies, but we have to check for certain things. And because things are getting so complicated, I propose to calculate the numbers, which is more objective probably. And there are different risks that are calculated, for instance, the score, and the Framingham risk. You can also calibrate the Framingham risk with a calibration factor. And we also calculate from the TNT study as proposed by Dorstein, the risk in secondary prevention, which also can be refined with knowledge about renal function, previous myocardial infarction, heart failure, and so on. And we define also some high-risk patients based on atherosclerosis imaging, for instance, carotid total plaque area over 80 millimeters square, or a calcium score of more than 100 Agatston units. So this is a kind of pretest probability for the patient to define where he starts and where we start when we treat him. And of course, we have to check for bleeding risks. We shouldn't overtreat patients, especially if their risk is not high. So this is the calculator, and you see we can give some input variables here, age and so on, HDL, diabetes, smoking, also previous myocardial infarction. This is all secondary prevention section. Here we have the atherosclerosis imaging section. So this is a kind of defining the pretest probability of the patient regarding his risk. You can also define his renal function. It calculates the renal function, and the bleeding risk parameters are also displayed here. And when this is termed with yes, one of these things here, then you get an alert from the calculator to watch for increased bleeding risk. So what you get here is the results section. We have the Framingham risk, we have the score risk of the same patient, CVD risk in secondary prevention based on the TNT study by Dorstein, as mentioned previously. And we see what can be done with intervention regarding risk lowering. We see if aspirin may be indicated with a number needed to treat minus a number needed to harm. And we see here whether Xarelto Vascular may be indicated or not, and what is the goal of LDL. So when one of these things here is over 10 here, score, or over 30 for the secondary and primary prevention risk calculators, then you have a very high risk situation where you should get the LDL below 1.4. And it also tells you if the blood pressure goal in your patient is reached. You get the information about renal function and body mass index. And interestingly, you get also information about the cost efficiency based on cost per quality. And here you have to keep in mind that when you treat patients for 5 years, you may get 4 quality. But when you treat them for 20 years instead of 5 years, you get 16 times more quality. The cost efficiency is much higher after 20 years than after 5 years. That's why we have chosen this larger uh, um, field of time, because most patients won't stop their therapy after 5 years, as maybe some uh, economy scientists think. And here you have also the potential for risk reduction. So you can find the tool on the internet, and as said before, if you see some field for improvement, just contact us immediately. And here now we have the calculator we get through with some examples. Here we start with a female. She is 60 years old. Her blood pressure is 150. The blood pressure is treated. She has no diabetes and the cholesterol of 7, and the LDL, let's say 4, and the HDL is 1.5. Atherosclerosis was not measured. She is in primary prevention, and she is a little obese. Her renal function is normal, and she has no anemia, and the bleeding risk is apparently low. So here we have some more information. The calibration factor can be chosen here. You can choose here the daily cost of the therapy, of the high cost therapy of PCSK9 inhibitors. So when you write here 13, then immediately you see the change here in the cost efficiency. So when you treat with daily costs of 5 francs, you get a return on investment, of course. But when you have the average costs of about 15 francs per day, then you see in this patient adding PCSK9 inhibitors wouldn't be cost efficient. So now let's look at the results. So we see in primary prevention, this patient would have a risk of 18, in secondary prevention of 15, and the score risk is 2% in 10 years. So this is intermediate risk situation where the calculator says do not use aspirin. There is no apparent indication for Xarelto at an intermediate risk, according to the new guidelines 2019 of the European Society of Cardiology. You should reduce the patient's LDL if dietary effects are not enough, with statin to below 2.6 millimole per liter. And you also see that the blood pressure goal in this patient is not reached. The renal function is normal, and the body index is slightly elevated. And here the cost efficiency for statins and for ezetimibe, and if there would be an indication for rivaroxaban, you see that there is a highly cost-efficient situation. So maybe we shouldn't just treat only high-risk patients with this, but that's another discussion, maybe another time. So now we come to the next step, where we look at a high-risk patient, and now we change this patient to 65, and immediately watch what happens here. You see the patient now is a high risk according to Framingham, and the blood pressure is treated, and now let's say she's a current smoker. And you see now this, of course, increases the risk. Now aspirin may be appropriate in this situation with a number needed to treat minus number needed to harm of 41, so that's good. And Xarelto Vascular may now be indicated, and the LDL goal should be below 1.8. So when you write here 1.2, then the LDL goal is reached. So, and here we say we have to go to 120. So if we had this put in, then the blood pressure goal would be reached, and the patient would be categorized as moderate risk. So this is just to show you how quickly you can change things and get an information about the situation of your patient. So we go back to the high-risk situation. Now this patient is 65 years old. Her height is 168 and 79. So now we use the Cockcroft formula. We give a creatinine of 120, and you see that her renal function creatinine clearance is 51. So Xarelto may not be indicated, but that's another question. And you see aspirin is cost efficient. She's very high risk and she needs an LDL below 1.4. So that's about the information we can get, and also all these informations about the cost efficiency issues. And you will see that when you calculate cost efficiency over 20 years, you will see how cost efficient in fact we are. So if we put this patient with an LDL of 2.4, sorry, 2.4 here, then we say or 3, then based with this risk 3.1 here, even PCSK9 inhibitors would be cost efficient. If we lower the LDL, we get a highly cost efficient therapy with PCSK9 inhibitors. So when we go back to 2.3 LDL, it wouldn't be the case. But if we make this patient to a male, which increases his risk, then PCSK9 inhibitors would be very cost efficient because risk is now in secondary prevention 44%, and in primary prevention 64%, and score risk is 14%. So that's all about the situation that we can offer to you with this calculator, which is called Aspirin Statin Compass. And I hope you will try it out and send us some feedback if you liked it or what we could improve. Thank you for your attention.